Now that we have a clear picture of what surrounds the liver, let's go inside. And the best place to start is the Porta Hepatis. This is where several important structures are entering and exiting the liver alongside one another. I'd like to talk about the shape and structure of the porta itself, and the anatomy we find within it, the bile ducts, hepatic arteries, and portal veins. At the Porta Hepatis, a surgeon must carefully dissect through the hepatoduodenal ligament, a connective tissue sheath, to locate the ducts and vessels. This tissue is continuous with the peritoneum covering the liver, and penetrates the interior of the liver as well, wrapping blood vessels and ducts together like a bundle of cables, into what are called portal pedicles. If I remove the illustration overlay, you can get a better sense of that thin tissue in this image, which is from a pediatric patient, so the tissue is extremely thin and translucent. For a surgeon, something like this might be the end goal of dissection, where you can visualize each structure clearly. But because of that ligament, when they first enter the porta, this is what they're looking at. If we followed that tissue inside the liver, we would eventually find that it surrounds each bundle of portal triads, penetrating inside the liver for about a centimeter or so. These bundles of portal triads are the portal pedicles. This feature of liver anatomy can contribute to the behavior of certain pathologies, such as Klatskin tumors, which I'll discuss later. This tissue also thickens beneath segment 4, and this thickening of the pedicle tissue is referred to as the hilar plate or biliary plate. As it thickens above the left portal vein, it is referred to as the umbilical plate. And above the gallbladder, not shown here, is the cystic plate. Before we discuss the vessels and ducts, I'd like to talk about an aspect of this region which I think is important for medical illustrators. I realized while editing footage that I had been previously depicting this junction of the liver and Porta Hepatis structures incorrectly. I had had the structures enter the liver by having them dead end into a flat plane, and I've noticed that the Porta Hepatis is often depicted in this manner, especially with 3D models, but I would argue that is incorrect and misleading. There is a cavernous nature to the porta, and I've tried to capture that characteristic ever since. Just as in figure drawing, anatomy does not exist in isolation. You have to know surrounding structures to make a convincing representation. I think including this degree of detail gives a better indication of the three-dimensional relationship between the structures in this area, and orients the viewer to better appreciate how they branch within the liver. You will find this invagination of liver tissue occurs wherever there is a structure entering or exiting the liver. Depending on what is taking place in a surgical procedure, these spaces may become relevant to the story. So rather than dead ending into a flat bottom plane of the liver, you should actually see the tissue cave in or invaginate at this point. But not in such a way as where each individual structure penetrates through the surface, but rather in such a way as to coincide with major divisions, because the way the liver tissue envelops the vasculature and bile ducts follows the pedicles. Now that we've covered the general structure, let's look at the elements we find within, the bile ducts and vasculature. For a porta dissection, a surgeon will dissect through the hepatoduodenal ligament, and first look for the bile ducts, the most superficial structure in the porta. The images here are from a living donor right hepatectomy procedure, with a patient who had had their gallbladder removed in a previous operation. The first bile ducts one would look for are the cystic duct connecting the gallbladder and the common bile duct taking bile from the liver and gallbladder towards the duodenum. You would expect to find the common bile duct traveling along the right side of the portal vein. The goal at this point is to locate the division of right and left hepatic ducts. Commonly, this bifurcation will be anterior, lateral, and superior to the portal vein bifurcation. The common hepatic artery and its branches will likely be found to the left of the main portal vein. The arteries in the porta are, generally speaking, deep to the bile ducts, but still superficial to the portal veins. Consistently, we find the bifurcation of the main left and right hepatic arteries will be anterior, medial, and inferior to the portal vein bifurcation. Even though the portal veins are deep to the arteries and ducts, they are the easiest to view on CTs, so they are most often used for orientation. The main portal vein bifurcates soon after entering the Porta Hepatis, and this bifurcation cradles segment 4B. It's sometimes referred to as the saddle. This bifurcation is also useful for orientation during surgery, because it is so highly consistent with the bifurcation of the bile ducts and hepatic arteries. Arteries can also be seen on contrast CTs, but they are smaller and less predictable than veins, so not as reliable as landmarks. Most difficult to visualize are the bile ducts. Now that we've covered the porta, let's follow those structures we found inside the liver, and we'll start with those tricky bile ducts, the most superficial structures found in the porta, which drain bile from the liver. We're going to discuss the cystic duct connecting to the gallbladder, the main left and right bile ducts, and follow those into some segmental branches. To begin, just a few general statements about bile ducts. Contrary to depictions where the duct is smaller than arteries, bile ducts can actually be quite large. In fact, they're usually often thicker than arteries. Segmental ducts will more closely follow the course of portal veins than of arteries, but there can be deviations. So it's important not to assume that the bile ducts will follow portal veins exactly. One should keep alert for variance from what is considered normal or ideal. Bile ducts can be a bit perplexing to deal with for us because they are usually not visualized in preoperative imaging. They sometimes will be during surgery. We almost always have to reconstruct bile ducts with a degree of artistic license, but I think this idealized anatomy is a good place to start anytime you want to illustrate a surgical procedure involving bile ducts. More so than arteries or portal veins, the bile ducts themselves can be near continuous with the pedicle sheath tissue, and this means that when dissecting through the pedicle, there's a risk of stripping the bile duct as well. The bile ducts are most intimate with the biliary plate at the bifurcation of the right and left bile ducts. So often, when a duct needs to be divided, surgeons will just staple off the entire pedicle. One duct that is almost always dissected out individually, though, is the cystic duct. The cystic duct will often have a curvature to it, and it can be unpredictable as to its location. This can lead to mistakes in cholecystectomies. The left hepatic duct drains bile from the left lobe of the liver, and will probably exist for a good length before giving off branches, whereas the right bile duct will divide far more proximally, which is especially evident here. This is an example from a living donor right hepatectomy. Let's zoom in a little bit, and you can appreciate how segmental bile ducts are branching quite close to one another. So if you're a surgeon and you have to divide bile ducts to resect a very specific piece of liver, you really need to know precisely where to make that cut. In a living donor right hepatectomy, the bile ducts need to be cut so that the entire right lobe is included. In this case, it was deemed safer for the donor, who would be keeping their left lobe, for 2 divisions to be made. This yields 2 bile ducts to be reconnected in the recipient, but it keeps that division far away from the left bile duct so that the remaining biliary tree is safely intact in the donor. I also rendered this in stereo just for funsies. During surgery, a common technique to identify the correct locations of ducts is to place a metal clip at the edge of a duct and use an intraoperative X-ray to perform a cholangiogram. Cholangiograms are an essential part of operative planning, especially in living donor liver transplantation. I'd like to show you another cholangiogram image that served as the initial basis for my next set of models. This is roughly what we're looking at. You can appreciate how difficult it is to discern things from a flat 2D image. Surgeons have to do this all the time. This is an example of a revision process in trying to pin down the exact locations of some very abnormal bile ducts. I started off getting just about everything wrong, but it was during this case that I started to gain an understanding for how the bile ducts travel in line with the portal veins. Here I also added that characteristic curve to the cystic duct. Here I thought I had it figured out, but I was still far from correct. So we went back to the imaging and found a set of MRIs where we could see the bile ducts a little better. This was the image my surgeon used to point out to me that the segment 4 duct in this patient was emerging from the segment 8 branch of the right bile duct. And this was the configuration we settled on. You can see that this bile duct anatomy defies convention. It's quite different from what I showed you here, in this idealized anatomy. In this patient, the segment 1 duct branches off by itself, but there is no true left and right division, rather more of an anterior and posterior division of bile ducts. Segment 2-3 flows along the posterior edge of the left portal vein, and the segment 6-7 duct continues posteriorly. Segment 4 and segment 5-8 are together anteriorly. When we look at the MRI series in a medical imaging application, having been told where to look, you can indeed see that this is the case. The segment 4 duct is emerging from the segment 5-8 duct anterior to the left portal vein. Most surgical procedures that involve removing a large portion of liver will require reconnecting the flow of bile from the liver to the intestines. Often when they do this, it will appear as though they are attaching the bowel directly to the cut surface of the liver. Actually, what they're doing is connecting the mucosa directly to the cut end of a duct. And you may wonder why they don't instead use some kind of a shunt, a synthetic tube or a vein graft to reestablish this connection. It's because the bile ducts are vascularized. Like major arteries, bile ducts receive their own blood supply. If this blood supply is cut off, the structure will die. But while bile duct injuries are a major issue of concern in HPB surgery, bile duct cancer is an even greater concern. These are known as Klatskin tumors, and they are one of the most aggressive forms of cancer that HPB surgeons deal with. This cancer will develop at the bifurcation of the left and right bile ducts, which it will block and lead to jaundice in the patient, and eventually lead to liver failure. The tumor can spread along the ducts into the nearby porta structures, and it can even creep into the hepatic veins, which may then lead to a caval resection and reconstruction. We'll take a look at hepatic arteries now, the vessels that bring oxygen-rich blood into the liver. We'll look at the left and right hepatic arteries, secondary branches into liver segments, and we'll discuss some anomalies as well. The common hepatic artery and its branches are most often found deep to the bile ducts. Arteries behave and appear a bit different from the other structures we find in the porta because they are under higher pressure. You will note in this image that commonly we find the major division of the hepatic artery into left and right takes place outside the liver, as do the first few segmental branches, which may include the segment 1 or caudate artery. This can emerge from the main hepatic artery, as depicted here, or it can also branch off the left hepatic artery. Here are some examples of segment 2 and 3 arteries, and a segment 4 branch from the left hepatic artery, which, as you can see, can be found during porta dissection. We often find that the right hepatic artery branches off early, crossing over from the left side to the right. Off the right hepatic artery, we'll expect to find an anterior branch supplying segments 5 and 8, and a posterior branch supplying segments 6 and 7. This is an example of where we find there is a distinct division of the right hepatic artery that coincides with an anterior and posterior division. But that is not always the case. This is a different patient where we see a segment 6-7 branch and a segment 5 branch that occurs separately from the segment 8. Of course, all these branches become quite distorted when there is nearby tumor involvement. Within the liver, variations on arterial branches are dealt with as they are encountered, but preoperatively, surgeons will look to see if there are major deviations. An important anomaly to consider are replaced left hepatic arteries. These can occur in about 25% of people and will usually come from the left gastric artery. In this case, it's coming off the right gastric. Less common are the replaced right hepatic arteries. When these do show up, they will usually come off the superior mesenteric artery, and they will almost always be a total replaced right, which is to say they will supply the entire right lobe, segments 5 through 8. Surgical repair of arteries is a delicate task, as these vessels are quite small. One intuitive approach is to simply sew them together end to end. This is an example from a pediatric liver transplant where the arterial anastomosis was performed under a surgical microscope. Here, a series of interrupted sutures, as opposed to one continuous running suture, was used to allow for expansion of the artery as the child grows. Some situations may call for a different approach, such as a parachute technique, where a running suture is used to gently pull the arterial ends together. We'll now move on to the portal veins, which bring nutrient-rich blood from the digestive system into the liver. I'll talk about the main left and right portal veins, major segmental branches, some smaller but significant branches, and then touch on some surgical considerations. To begin, I'll point out that even though the portal veins are deep to the arteries and ducts, and are therefore encountered last during dissection, they're still the largest structures, and the most easily visualized on preoperative imaging, both MRI and CT, so where they branch will often be the basis for the surgical plan. As the portal veins branch within the liver, they travel through the center of each liver segment, as opposed to the hepatic veins, which travel within the border between these segments. The left portal vein will provide the primary inflow to segments 1 through 4. An important surgical consideration of the left portal vein during dissection will be its branches to the caudate lobe, of which there are usually 2. Some interesting features of the left portal vein: the segment 2 and 3 branches are frequently 2 distinct branches off the main left, with a short length between them. You don't often see a common trunk. And the left portal vein has a distinct curvature, which surgeons will seek to reestablish if a transplant calls for anastomosing to a recipient left portal vein. This was an important aspect of a recent case we did depicting a left lateral segment liver graft implantation, which called for an unintuitive technique for reconstruction. To find out more about that, please visit our site to view the case. Mainly, the right portal vein will supply the right lobe of the liver, and there are some interesting features of it I'd like to point out. I'm going to talk about some small but surgically significant branches, and then talk about some variations of the more prominent branches. Proximally off the right portal vein, there will almost always be a small branch providing inflow to segment 6, and this is surgically significant. Our surgeons have named this one of 2 annoying veins, because to properly mobilize the right portal vein, you have to take this vessel. Due to its posterior location, it can be quite difficult to access, and as you can appreciate here, also difficult to see. Here we'll zoom out a little bit, and you can get a better view of it. Similar to the caudate veins, if you don't carefully ligate and divide this vessel, it will easily rip and tear a giant hole in the back of the right portal vein. This becomes a major annoyance to repair, results in additional blood loss, and prolongs the total length of the procedure. So to safely mobilize the right portal vein, you have to carefully dissect out, ligate, and divide the annoying vein. In this procedure, the annoying vein was found off of one of the right portal vein branches, which I'll speak more about in just a moment. This is also a good example of what surgeons mean when they say mobilize, because there is no way you can fit a stapler around that right portal vein with the annoying vein still intact. The right portal vein often has a discernible division between anterior and posterior. These are the right anterior portal vein, supplying segments 5 and 8, and the right posterior portal vein, supplying segments 6 and 7. This division is one of high variabilities. They can branch from a short common trunk, as seen here, or a longer, more distinct common right portal vein. Sometimes, though, that short common trunk is barely discernible, and this might be referred to as a trifurcating portal vein. But you can also have that anterior branch, which supplies segment 5 and 8, emerge distally, even as far as off the left portal vein. This particular configuration is the most rare, but it's something surgeons will want to look out for. Now, before I show an example of the portal veins in surgery, I'd like to just briefly talk about a different system for viewing the portal vein divisions. There is a group of Japanese surgeons who argue that the right lobe segmentation needs reclassification based on this alternative view of the right portal vein branches. In the Quino system, as we look down on the portal veins of the right lobe from above here, segment 5 and 8 branches will emerge from the anterior branch of the right portal vein. Segment 6 and 7 branches will emerge from the posterior branch of the right portal vein. The Japanese system can be illustrated thusly. We relabel that previous image to emphasize dorsal and ventral branches of the right anterior portal vein. These 2 branches of the right anterior portal vein are quite common. We do see them in the majority of patients. So instead of the right lobe being divided like this, it might look something more like this. It will be interesting to see if this new classification system gains momentum, as this could change the approach for certain resections. Ultimately, though, the point is not to get too caught up in dogma. You want to look at what the patient presents and not allow preconceived notions to cloud decision-making. And that's illustrated well in this case. I'm going to wrap up with an extended left hepatectomy with a complex portal vein reconstruction for a demonstration. This is from a case we saw where a Klatskin tumor had enveloped the middle hepatic vein and portal bifurcation. Preoperatively, an extended left hepatectomy was planned, removing segments 1 through 5 and 8, leaving only segments 6 and 7. In this patient, there was a 6-7 and an accessory segment 7 vein, both of which would require reconstruction. So as you can see, the operative plan is all about adjusting to the patient. So after transecting through the liver, these vessels are identified. The transection is complete, the specimen removed, and the remaining main portal vein brought over for 2 anastomoses, one to the accessory segment 7 branch, and one to the main segment 6-7 branch. You can see that for the second reconstruction, a small length of vein graft was used. Stay tuned for the next video in this series, where TVASurg team leader Albert Fung will cover structures below the liver and share some of the most significant revelations we've come across in our experience of making 3D animations for HPB surgery.